CurePSP's mission is to provide education and support for people and their families affected by PSP, CBD, MSA, and related brain diseases, while funding research towards a cure and prevention. Webinars are made possible by the generosity of donors and other supporters. My name is Bruce Ginelli, and I am the Director of Communications and Marketing at CurePSP. The topic of our webinar today is PSP Back to Basics. It is my distinct pleasure to introduce to you today Dr. Amy L. Peterson. Dr. Peterson is a movement disorders neurologist at the Portland VA and Oregon Health and Sciences University. She completed her medical school training at the Medical College of Georgia and her neurology residency at Brown University in Providence, Rhode Island. She completed a clinically based fellowship on movement disorders at UMass Medical Center and then relocated to Oregon to complete a research-focused movement disorders fellowship. In Oregon, she has been active both with clinical work and clinical research. Her research focus is on gait and balance problems in Parkinson's disease. She is specifically looking at vitamin D as a novel therapy to improve balance in Parkinson's disease. In addition, Dr. Peterson has been involved with legislative advocacy work since early in her residency. She worked in Senator Jack Reed's office as the American Academy of Neurology, the American Neurological Association, and the Child Neurology Health Policy Fellow in 2004. She continues to serve on the American Academy of Neurology's Government Relations Committee and locally on the Advocacy Committee for Parkinson's Resources of Oregon. Amy?
Thank you. Good afternoon, everyone. So this is my first time doing a webinar, and I hope it goes well. I'll try to speak slowly and clearly so everyone can hear. So this is basically going to be just an overview on the basics of PSP, or progressive supranuclear palsy. As Mr. Ginelli said, I am here in Oregon at Oregon Health Sciences University, and I also work at the Portland VA. And to just outline what we're going to talk about, we're going to talk about first the historical context of PSP. And I think this is just important to understand how new this disorder really is in our understanding of it. And then we'll talk about the different names for PSP. I think this comes up a lot, that people get confused where they've been told it's one thing and then another, and there's different names it can go by. So it's good to have a sense of that. I'll then talk about what the classical description of PSP is, but that there's also some related variants, and that's where some of this confusion comes at times with the names. I'll talk a little bit about the pathology of PSP, the epidemiology, the etiology and genetics, and then talk a little bit about treatment, research issues, and then resources that are available for persons and families of people with PSP. So, progressive supranuclear palsy, or PSP, was first described by J. Clifford Richardson, and this was only in 1963. So again, this is a pretty recent entity to be understood, and this is a picture of Dr. Richardson there. He described the classic form of progressive supranuclear palsy, and this is characterized by problems with falling, worsening memory problems, progressive stiffness, which is especially central in the body, so that's what we call the axial muscles at times too, the neck, the abdomen, the pelvis, supranuclear gaze palsy, which this is trouble with looking down voluntarily, and I'll go through this a little bit more later, and then bulbar palsy, which means trouble with the throat area. The bulbar is the throat area that relates to swallowing and speech. So as early as 1857, Dickens may actually have described someone with progressive supranuclear palsy, or PSP, in one of his writings. He describes a chilled, slowed, earthy, fixed old man, a cadaverous man of measured speech, an old man who seemed unable to wink, as if his eyelids had been nailed to his forehead, an old man whose eyes, two spots of fire, had no more motion than if they had been connected with the back of his skull by screws driven through it, and riveted and bolted outside among his gray hair. He did not bend himself to sit as others do, but seemed to sink bolt upright as if in water until the chair stopped him. So this description may sound familiar to some people either who have PSP or family members with it. And we often really think about this just lack of blinking. There's a lot of stare involved, and then this really extreme stiffness, especially again through those central muscles. So what is PSP? It's a progressive neurodegenerative disease, and what this means is it progressively gets worse over time, and it involves a degenerative process of the nervous system. It's thought to have a number of different subtypes, and we'll go through those. And sometimes there can be overlap between these subtypes and then also overlap with some other syndromes. So again, that can make things a little bit unclear and confusing at times. So other names for PSP are progressive supranuclear palsy. Sometimes it's called a Parkinson's variant. Sometimes it's called a Parkinson's plus syndrome, and this can include other syndromes as well. Sometimes it's called a tau apathy, and this is because of the pathology that we actually see, and we'll go through this. Sometimes it's called Richardson syndrome, and this is because Dr. Richardson was the one who first described it, and this usually refers to the classic form of PSP. It can also be called PSP Parkinsonism, and this is when it looks a little bit more like Parkinson's disease. And then there's also a variant called pure akinesia with freezing of gait. And akinesia means a lack of movement, so it's people with very slow movement, and freezing of gait is when the feet get stuck when someone tries to walk. So people might know this from having experienced it again or having seen other people who do. We can see freezing of gait in Parkinson's as well, but sometimes it can be really dramatic in these patients. So they'll have a lot of slowness and then this severe freezing of gait where they just can't get their feet to go forward. So what happens at a cellular level? So at a cellular level, we see something called tau. And tau is a protein, and these pictures here show the tau within the brain. And this is why we sometimes refer to PSP as a tauopathy. And it's not the only tauopathy, but it's one of them that we see. So this is where the term tauopathy comes from. So related syndromes, there's other syndromes caused by tau, as I just said. One is called cortical basal degeneration. That's also known as CBD. There can be a progressive aphasia, and an aphasia is trouble with language, so the trouble with language really predominates. There can be this pure akinesia with gait freezing, which we just talked about. And the thing that determines what symptoms we see if someone has tau in their brain is where the tau is. So depending on which part of the brain is affected with the tau, different symptoms are present. So this slide I really like because it shows how there's a lot of overlap between these different syndromes. And it's certainly not something where I expect people to look at it and memorize all these different things, but it can be something that's helpful in understanding why you might see one doctor and they kind of might say one thing, and then you might see somebody else and they might think about something else, or someone might say, well, it could be this or it could be that, because if you look at where the boxes come together, there's often overlap. And within the progressive supranuclear palsy, which we see to the right there, the gray box, there's quite a few other boxes that come in there. And then if you look at the bottom, the arrow shows on the left side more cortical involvement, and then on the right side more brainstem involvement. And the cortex is the higher part of the brain, closer to the outside of the skull, and then the brainstem are the deeper structures within the brain, and those are often more involved in the eye movements, in speech, in swallowing, whereas that cortical area can be involved more in language function, so not the speech itself, but the production of appropriate words, word finding, things like that, as well as motor function and some other issues. So that's kind of the distinction there. And again, a pretty complicated slide, but just to understand that there's a lot of overlap here, and so that's why things can sometimes seem a little bit unclear because there is overlap. So what about PSP symptoms? So some things about the people that we see with PSP, it basically does not present before age 40. So we really don't see people younger with 40 being diagnosed with PSP. The average age of onset is about 63, and about 50% of people who have PSP have this classic PSP form, which is also known as Richardson syndrome. Again, the gentleman who first described it. And in these people, we generally see a symmetric slowness and stiffness, so it'll affect the right and the left side about the same amount. They have this vertical supranuclear gaze palsy. Again, this is trouble looking down, and I'll describe this a little more. And they have very significant problems with balance and falls. So generally, people who come in with a PSP diagnosis, when they're initially given the diagnosis, they're already having trouble with balance and falls at that point. So about 30% of people with PSP have more of this PSP Parkinsonism. And Parkinsonism refers to some of the symptoms we see in Parkinson's disease, but these aren't people with Parkinson's disease, but more so a PSP that looks a little bit more like Parkinson's disease, if that makes sense. So in these people, we tend to see a little bit more asymmetry. So one side would be affected more than another. We often would see a tremor. It's often a rest tremor, like we again can see in Parkinson's disease. And they may initially respond fairly well to a medication called levodopa. And this is a medication, is the primary medication that we use in Parkinson's disease. And we often will try it in people with PSP, but usually there's not a great response. But in this subset of patients, we may see a pretty good response initially. So then last common is that more complicated one that I talked about, known as the pure akinesia with freezing of gait. And this, the walking problems, especially including the freezing where the feet get stuck and really can't move, are present pretty early on. They also tend to have small handwriting, and the voice is often quite soft. So that is that variety. So now to go on to talk a little bit about the different symptoms that we see within progressive supranuclear palsy. So there tend to be pretty significant vision problems, and people will often talk about trouble with reading as part of this, and they will have trouble with looking down, and this is what the next slides are going to show. It's a little difficult to show this without a movie, but I'm going to try here. So this is looking straight on at someone who's looking straight ahead, and we ask them to look down. This is somebody without progressive supranuclear palsy, and they're able to do that. No problem. They're not moving their head. They're just moving their eyes to look down, like if you were looking down at your shoes. We ask someone with progressive supranuclear palsy to look down, and they may not be able to do it, or it might be quite difficult. So when they try to look down at their shoes without moving their head, they're not able to do that, and their eyes stay up higher. But if we tilt their head back, if we move their head, then we're able to get their eyes to move down. And this is what's known as supranuclear gaze palsy. If they couldn't get their eyes to move down even with moving the head, then it's a different type of gaze palsy. So this is what we mean by supranuclear gaze palsy. And this is a little bit of a difficult concept. We weren't able to show this link here, but this could be something that you could type in and see a video that would show this in a patient is somewhat helpful. And this comes from this Massachusetts Harvard Medical School, Mass General Hospital, from their site. So that you can look at if you'd like to see that in a different form. So hopefully that made sense. We also see speech and swallowing problems. So people tend to have speech that sounds somewhat abnormal. It's often not as clear as they would like. It can be soft. It sometimes can have an unusual pattern to it. And then we also see swallowing problems. So they can have difficulty with coughing and choking on food, difficulty with eating certain types of food, and this can be a really significant problem. And often is something that in later stages can result in death for somebody, because if the food isn't going into the right place and it's getting into the lungs, we can then see pneumonias develop, aspiration pneumonia. So this is something important to keep a close eye on. It's important that people know how to do the Heimlich maneuver, and it's important that they work closely with speech therapists and have swallow studies done regularly so that they're eating the right consistency food and doing everything they can to prevent this from happening. So balance and falls, as I said, we often see problems with falls early on in people with PSP. They often tend to fall forward, and they tend to have poor balance. So that seems to be largely the culprit of the falls. And we do also see that oftentimes they don't have a lot of cautiousness with things. So they'll fall, they'll continue to get up and do the same patterns of things that caused them to fall in the past. In other patients who have falls, we often see that fear of falling becomes a big issue. And in PSP, that doesn't seem to be the case. There often is kind of almost a disinhibition, we describe it as, where they know that they're going to fall but continue to engage in these behaviors that cause them to fall, and this can make treating this quite difficult. We also can see memory and mood issues, and I'll talk a little bit more about these when I talk about ways to treat them. In terms of the memory issues, you may see trouble with language function, specifically short-term memory as well. Mood issues can be issues of depression, anxiety. And then we can also see personality changes. And this kind of goes along with the mood a little bit. But apathy is really one that we can see. And this can oftentimes be pretty easy for the patient to deal with. But for caregivers, this can often be quite difficult because there's just kind of this whatever sense. And I think this cartoon kind of gives a good approach to what apathy looks like. So in the radiology of PSP, so what do we see in the brain when we look at imaging in PSP? So this is that brainstem area, which is that lower part within the brain. And we have three segments here, the midbrain, the pons, and the medulla. And the one on the left side is a normal brain, and the midbrain we see is pretty big there. In the PSP brain, we see that midbrain gets smaller, and then it looks like there's kind of this big outpouching of a belly. So we will call that sometimes the penguin sign or the hummingbird sign, because it kind of looks like the beak up here and then the belly of the penguin or of the hummingbird there coming down. This generally isn't used in terms of diagnosis, but is something we can see on radiology images in people with PSP. So who does it affect? It's about 6 to 10% as many people as Parkinson's disease. So definitely less frequent than Parkinson's, but not that infrequent. It affects about 6 to 7 people per every 100,000. We kind of mentioned this before, but I think it's good to reiterate that the peak age of onset is around 63 years old, and it basically does not present before age 40. Again, this is a disease we see as people get older. We do not see it in young people. That is different than Parkinson's disease. We often see Parkinson's as an older age, but we can see it in younger people. But PSP we really don't see in people before the age of 40. What causes it? It's likely a combination of genetic, and environmental causes. And these aren't things that we specifically know great detail about, but we think it's probably some interaction between these two. There's very rare cases where there's clearly inherited cases. So this is pretty uncommon. So generally I will have patients when they're first diagnosed, they'll often ask, oh, do I have to let my children know that they might be at higher risk for this? And for the vast majority of people, the answer is going to be no. It does not seem to be directly inherited by, again, the vast majority of people. There is some known toxin exposure to this plant that's shown here, and I'm not going to attempt to pronounce the name there, but consumption of that plant is known to cause PSP. So those rare things like that where we see a clear cause make us think more about these environmental causes, but for most people we don't have a clear environmental exposure that they've individually had, but we think overall, again, it's this relationship between genetic and environmental causes. So how do we treat PSP? Well, if there's slowness and stiffness present, it's often reasonable to give levodopa a try. And levodopa comes in the form carbidopa-levodopa. It's also known as Sinemet. And again, this is the best medication that we have to treat Parkinson's disease. And one of the symptoms of Parkinson's that it often treats well in Parkinson's patients is slowness and stiffness. So if someone has a prominent degree of slowness and stiffness, I generally give this a try. Usually get it up to a pretty good dosage, around 1,000 milligrams a day. If someone doesn't have benefit, then we can get rid of it, or if they have problems with side effects. And it's very individually dependent whether there's much of a response. Often early on in the disease, there'll be a bit of a response, not dramatic, but some improvement. And then over time, we tend to see it not working as well. There's a medication called amantadine, and this was actually originally developed as an anti-flu medication. And it may help decrease falls in patients with PSP, and I have a number of patients who find this particularly helpful. It's given in doses of 100 milligrams, and generally we start it at once a day, and then we'll often go up to 2 or 3 times a day, and occasionally as high as 4 times a day. It can keep people awake at night, so it's important to try to take it a little bit earlier in the day. It's important to increase it gradually, and then also to decrease it gradually if that's necessary to come off of it. And it can cause problems with worsening confusion. It can cause leg swelling. It can cause a rash on the legs. The rash itself isn't a big problem, but sometimes the other side effects can be problematic. So again, if someone's having trouble with falls, this is something worth considering trying. There's a lot of therapies that are more supportive, and we'll kind of go through these a little bit more, but these are things like working with speech therapy, changing diet, working with physical therapy, working on techniques to try and make people safer and avoid situations where they're going to fall, things like that. In terms of the memory problems, there's some question if cholinesterase inhibitors, which are medications like Aricept that were created to treat Alzheimer's disease, if they'll be helpful. And the studies are kind of mixed. It's not entirely clear, but probably for most people, they're not going to offer a lot of benefit in terms of memory. There's some very modest research looking at coenzyme Q10, which is a supplement. It's something you can get over the counter. And there may be some benefit with that, but there really haven't been good enough studies to say one way or another. Some of the thoughts for looking at that came from some of the Parkinsons research again. And the Parkinsons study recently came out, a large study that was done on coenzyme Q10, and didn't find any benefit. So I think with that data coming out, I'm a little less hopeful that coenzyme Q10 will be of benefit, but it may be something to consider, but we need a little bit more research to say for sure one way or another. So let's talk about the apathy and depression a little bit. How do we manage that? So sometimes stimulants can be appropriate, and these are medications like Ritalin. These are the things that your children and grandchildren might be on for ADHD, and these can sometimes be helpful. Antidepressants can sometimes be helpful. Psychotherapy is often helpful, so talk therapy, talking with a therapist. Support groups are really important, and organizations like PSP, CurePSP can be helpful with resources like this. But it's really important to have a support network around, and support groups can really be helpful this way. And it's important that there's support both for the patient and the spouse, because often the mood issues with the patient develop into mood issues with the spouse. The spouse is having more stress with caring for the patient, and it's important that we support both of them, and support groups are a great way to do this. So going on to the impulsivity, I kind of mentioned this a little bit, and this is often seen in relationship to falls. And so again, we'll see someone who gets out of a chair and falls down, and they continue to do this behavior, not grabbing on properly, not using their walker, when they know that they're going to have a fall if they don't do those more careful things. And the way to work on this is to really try to work on reinforcement to avoid risky behavior. So if it's something where someone needs to use their walker every time they stand up, working with them and saying, what do you do every time you stand up? You get your walker, and using it where you have a very set question, a set answer, and you do it every time. And if you have them physically run through it too and grab their walker as they do it, this can be somewhat helpful. Close supervision is also important to try and prevent people from getting themselves into bad situations. So if someone's able to be there, keep an eye on things and try to see if they're being as careful as possible. But this can be fairly difficult and can seem a little frustrating at times because you're trying to prevent this person from hurting themselves, and they often are engaging in these behaviors. There's just not an understanding, it seems, to try to avoid these. So the vision problems. Oftentimes reading is one of the biggest complaints, that people feel like they can't read properly. And this has to do with the trouble with moving the eyes properly. So they're not lining up properly. So they're working in terms of what they're doing individually, but when you use both together, they're not getting quite where you want them. One solution may be prisms, which helps to move the eye in. It's something you do with a pair of glasses. You might want to try using a ruler when you read, and some people find this very helpful because it helps them to track across a line better if there's a ruler there. Oftentimes placing objects and food at eye level can be helpful. So again, that main problem is looking down, and you can think if you were sitting at the dining room table and had your food a little bit below you, it's going to be pretty difficult to look down and see that food. And people often say early on that they notice that the person with PSP has food on the front of them and has gotten to be a messy eater. They'll describe it that way. So if you're able to raise the food up, that often is quite helpful. So if you can put it up higher at eye level with a book, if you could get like a holder that would put it up at eye level or hold it closer to eye level, that can often be helpful. Dry eyes are also often a big problem because there's not as much blinking going on. As we said, oftentimes there's this stare, and artificial tears can be very helpful for this, and they often need to be used really liberally. Dark glasses can also be helpful because, again, there's not a lot of blinking, so there's more light getting into the eyes, and sometimes people find dark glasses helpful with this. Some people even use them indoors. If there's trouble with actually opening or closing the eyes, so not with the movements of the eyes, but opening or closing them, botulinum toxin injections might be something to consider. And yes, this is the medication used for wrinkles. The reason it works for wrinkles is because it weakens muscles. So if muscles aren't working properly, sometimes we can use this as a treatment. You can also be referred for low vision services, and this can be helpful in terms of getting books with larger print, books on tape, and kind of finding other ways around the vision problems themselves. Another thing that I always like to stress, and I try to do this early on, is that bifocals and transitions can be really difficult for people with PSP. So what happens with the bifocal and the transition lens is you need to get your eye into the right place of the glasses in order to use the right part of the lens. And again, because there's this trouble moving the eyes properly, you're often looking through the wrong part of the lens. And anyone with bifocals has probably had this experience of when you're trying to walk down a flight of stairs or something and look through the wrong part at the reading part, and that's not too helpful there. So oftentimes having separate glasses for near and far can be helpful if you need something like a bifocal or if you've had a transition lens in the past. The transition lenses are also quite expensive, so oftentimes I'll see people who go and get a new pair of glasses and then complain, oh, I can't see a thing anymore, and it's often because they've made this switch to these transition lenses. So it's better to try the separate glasses to start with. It'll be less expensive and likely more successful than these other types of glasses. So the speech and swallowing issues, the biggest thing is really to work with a speech therapy, with someone in speech therapy. And these can both be therapists who more are focused on swallowing issues, and they may do things like a swallow study to see how the swallowing is looking, and may recommend things like thickening liquids and changing consistency of diet, so perhaps avoiding things like steak that would be difficult to chew, even grinding up foods to making them softer and easier to eat. Also, assistive communication devices can be helpful, and this is PhD therapist who works with us, Dr. Fried Oken, who is able to do some things these ways, but there should be people all over, and these may be things like using a letter board where people can point to letters if they're really having trouble vocalizing. It may be something where it makes their voice louder, and there's many different devices that can be used here. So that's something to think about if there's trouble with communication going on. Again, food consistencies may be changed to help to prevent the problems with swallowing. And then caregivers should know the Heimlich maneuver. So this is something good to go through with your doctor if you're not aware of how to do that. Drooling, this is something that comes up and people complain about quite a bit. And we can use some oral medication sometimes for it. These aren't always particularly successful, but they may be worth trying. Unfortunately, they can make people confused sometimes, and sometimes when we dry up the mouth, people then actually notice they get a real thick saliva that makes it harder to swallow and is uncomfortable. Botulinum toxin injections, again, we can use these in the glands that make the saliva. This can be helpful with the drooling, but again, it can make a thick saliva, so this is something I counsel people cautiously about and would only use in fairly severe situations, because if the saliva gets this kind of thicker consistency, it can be fairly uncomfortable for people. The thing that I found that oftentimes works the best is chewing gum or sucking on hard candies. The reason that people drool who have PSP, and we see it in Parkinson's disease as well, is that they're not swallowing as often, and chewing on a piece of gum or sucking on a hard candy stimulates you to swallow more often, but yet it still keeps the mouth moist. These should be sugar-free gum ideally, and sugar-free hard candies, so you don't end up rotting your teeth in the process, but this can be quite helpful. So what about the gait problems? Like I mentioned before, amantadine is one medication that we can try and see if this helps with the walking, and especially with falls. Oftentimes people are going to recommend to use a walker. It's good before you get a walker to get evaluated by a physical therapist to make sure it's the right walker for you, that it's going to work on the type of floors that you have, that it's going to be transportable if you need that it's not going to be too light that you end up falling with it and injuring yourself more. So it's important to really be evaluated for what's the best walker. Also, Medicare generally pays for walkers every 2 years, so it's important to make sure you get the right one, because it's going to be a couple years before they would cover another one. Working with a physical therapist can be helpful, both to work specifically on the balance problems that are happening, and then, like we were talking about, those reinforcement issues to avoid the risky behaviors that are going to cause people to fall more. And then finally, exercise. Exercise seems to be extremely important in all of these neurodegenerative diseases, and really one of the few things that can really help to slow the progression of disease. And this is going to be very individual dependent. Again, it should be something that the person enjoys doing, so they're going to stick with it. It should definitely be something that's safe. So some people like treadmills, but these often aren't particularly safe if you're having balance problems or walking problems, and can cause people to fall. So something like an exercise bike might be more appropriate. And again, the way to kind of figure this out is to work with the physical therapist in a controlled environment, figure out what's safe and what somebody likes, and then try to continue those things on their own. So just to review PSP versus Parkinson's disease, because I think this comes up a lot and people don't understand what the differences are and get confused because they're told one or another. And there are a lot of similarities, so it can be difficult sometimes to make that distinction, especially earlier on in the disease process. So the similarities between the two, both we can see stiffness, so the muscles get stiff or rigid. Both we can see slowness, we call this bradykinesia, that things slow down. Both can have tremor, and both can have balance problems. So that's quite a few similarities there in terms of the clinical symptoms. What are the differences? Excuse me. So when we look at the brain, the pathology of people with Parkinson's versus PSP, it's different what we see. So the tau is what we see in PSP, and we don't see that tau in Parkinson's disease. Generally, the response to medications is different. So I mentioned the levodopa already, that if someone's slow and stiff, we'll often try this. But generally in PSP, this is going to be a fairly modest, maybe short-term response, whereas in Parkinson's disease, it's going to be oftentimes quite dramatic response. They're going to continue to get benefit from levodopa at 10, 15, 20, even 30 years down the road if they've had the disease that long. Generally, PSP progresses more quickly, so usually the symptoms get more severe in a shorter period of time than we see with Parkinson's disease. And again, this can be helpful in terms of following someone over time, where initially that distinction might be difficult, but as you spend more time with someone and see how the symptoms change, if they're changing more quickly, then we'd be more concerned about PSP. And then finally, which we've talked about quite a few times already today, is that the PSP patients tend to have more and earlier falls. So we see falls in people with Parkinson's disease, but it's usually quite a few years down the road, 5, 10, 15 years after they've started with other symptoms. In PSP patients, often when they're initially presenting, they're already falling at that point. So it's a little bit, the falls are again more common, and we see them earlier in PSP. So what about research in PSP? So this list here is from clinicaltrials.gov, and what this is a website where any trial that's funded with any sort of government money has to put the information about the trial on there. Also, other trials that aren't funded by the government can as well, and at this point almost everyone's putting their clinical trial information on clinicaltrials.gov. So what you can do is go into your computer and type in clinicaltrials.gov, just as it states there, and then you can put in what you want to search for. So you can search for progressive supranuclear palsy, and you can see, are there any research studies in my area that are working on progressive supranuclear palsy, and then it'll have information about the studies. So this was about a year ago, I believe, that I did this search, and there were 24 studies at that point, and I did it again yesterday, and it was up to 28. So a little bit of progress in terms of the number study at that time. And it'll say this column, the second column in, says status, and that tells you whether they're still recruiting. So that means if they're still taking patients, if they're not yet recruiting, so if the study hasn't gotten started yet, if it's active, or if it's completed. So if it's completed, they generally wouldn't be looking for any more subjects at this point. Also, what other forms of research do we have in PSP? And this I kind of was looking at to show how much we're trying to understand more about the disease. Again, it was in the 60s that this was first described, and this is a site that allows you to look up medical journals, and I have put in a search term, of progressive supranuclear palsy, and it brought up over 2,600 references. So there's over 2,600 papers that have been written related to progressive supranuclear palsy. Again, this was done a while back, and I suspect it's up a couple hundred in the last few months again. So it's a disorder we haven't understood a lot about in the past, but people are making strides to understand more about it. I wanted to just mention specifically some research that's going on here at OHSU. If anyone happens to be in the area and would be interested in participating in a study, it's looking at this postural instability and the falls that we see in PSP, and trying to figure out why do people with PSP fall so much. The patients need to have a diagnosis of PSP. They have to be able to walk 50 feet. So if someone's in a wheelchair where they can't ambulate, then they could not be in the study. But if they're able to walk 50 feet, they could be. There's some screening questions that would be done over the phone to determine if somebody was eligible for the study or not. And then it's a one-time 2-hour visit for balance testing. It's pretty intense balance testing that goes on, but they're getting a lot of great information. So if this sounds something like you're interested, Dr. Bernadette Schoenberg is the study PI, is the principal investigator on the study, and then the person to contact should be the coordinator, who is April Wilson, and her information is listed there. And what about resources? So obviously, if you're listening to this webinar, you know about CurePSP, and there's their website listed there. And this is a great organization, which is very helpful in terms of understanding more about progressive supranuclear palsy. I think for me, in reading a lot of their information, it's very straightforward, very clear, which is really can be helpful in understanding this difficult disorder at times. There's also a European organization called PSP. The website is PSP Eur, so it's pspeur.org, and that is their website, and they have some information as well that might be helpful if you want a little bit different perspective. And then finally, again, another thing to talk about that we're doing here at OHSU, if people happen to be in the area, it's really important to have interdisciplinary care for PSP. I've talked a little bit about the vision issues, working with the physical therapist, working with the speech therapist, and we have set up it's called Teen PD, and this is therapist education and aligned in managing Parkinson's disease. But in addition to Parkinson's disease, we're also focused on these Parkinson's plus syndromes as well. And we're doing a special conference in April, again here in Portland, that is focusing more on PSP and MSA. So this is another Parkinson's variant that we can see. And we're specifically focusing this for physical therapists, occupational therapists, speech therapists, social workers, and nurses. So if someone is in the area and this sounds like something they'd be interested in, the contact information is listed there. So that's all the information I had in the slides, but I have some time to answer questions, so we will start to move to that.
Yep, thank you so much, Dr. Peterson, for this wonderful presentation. At this point, we're going to go ahead and open it up to questions for people to ask. So everyone is going to see their screen change a little bit, and you'll see a little box at the bottom of your screen. Right there, you'll be able to type in a question for Dr. Peterson. So please go ahead and do that at this time, and she will try and field as many as she can with the time we have remaining today.
So someone put in the first question, and it said, did you say that there were forward falls in PSP? I've always heard of backwards falling. So that really depends on the individual, and people can fall both ways. And the forward falling, I guess I think of more when people have this kind of behaviors where they continue to engage in the same behaviors that cause them to fall. So often see people who get up from a chair and fall forward quite quickly, and sorry, I just lost the questions. And so we'll see those when people are kind of in this impulsive nature. They'll get up and fall straight forward, but we do see a lot of falls backwards as well, so it can go either way, and oftentimes individuals tend to fall one way or another. Okay, there we go. I'm back to the questions. I'm having a little trouble scrolling through them.
Yeah, there should just be a slide bar on the side of your screen for you to be able
Okay. Oh, there it is. Sorry, it was just hidden by the names of everyone. Okay, sorry about that. And then someone asked about the different stages of PSP, and we often think about stages in terms of level of ambulation. So, can someone walk on their own? Do they walk with an assistive device? Are they not ambulatory? And that's often how we talk about the different stages. How people progress through those stages is very individual. For most people, the past is the best predictor of the future. So if they've had a slow progression of symptoms, that often will continue that way. If they've had a more rapid progression of symptoms, that'll often continue that way as well. So that's kind of the basic, I would say, about the stages of PSP. The Richardson syndrome, the classic form, often progresses a little bit faster than some of those other varieties. Someone also asked a question of does this information apply to CBD or cortical basal degeneration? I didn't focus it specifically on that, so it is quite a bit different for a lot of it, but there are some overlap in some areas. But it was really more PSP focused, so that was kind of what I focused on today. Someone else has another question here. Let me see. And someone has a great comment about exercise. They talk about a treadmill that they have that had a lift in it called a light Gait that really helped his wife. And these treadmills can be great because they have a harness in them, and because of the harness, there's not the risk of falls that can happen with other treadmills. And often a regular treadmill, like I said, can be fairly unsafe. And he states that this really helped his wife, who had progressive supranuclear palsy, and that he strongly encourages a regular exercise program. And I would say I completely agree. Exercise is one of the most important things, and it's important to find a safe way to do it. And that's what's nice about a device like that, because it does keep it being very safe, where a regular treadmill isn't always quite so safe. Someone else says, I just got bifocals today. Should I throw them away? Not necessarily. I would say give them a try if you've already gotten them and see how they work for you. If you're able to get your eyes in the right place and they seem to work, then go right ahead. If you feel like they're not working and you really can't see out of them well, then you might want to get that type of glass, that prescription, but get it in a full glass. So oftentimes people have glasses like that for computer work when they're on a computer screen. So it's to help with near, but not just when you're looking down, because oftentimes that looking down is difficult. So I would say give them a try, see how they work. If it's something where you can return them, you might want to think about that. But if not, give them a try and see how they go. Someone asked, what do you know about a medication Davunetide, a medicine from Alon's being studied? Unfortunately, I don't know about that medication, so I'm not going to be able to comment on that one. Someone asked again another question kind of related to CBD. How do the two compare? So in CBD or cortical basal degeneration, we often see more trouble with the limbs themselves. So PSP tends to be more the central muscles, the axial muscles. In CBD, we often see one side quite a bit worse, oftentimes pretty dramatically worse. And often with that bad side, there'll be an inability to get the limb to do what somebody wants. We call, sometimes we say they have alien limb syndrome, which means that the hand or the limb does stuff that they don't even want it to do, and it seems kind of out of their control. They'll often also have something called dystonias, which is an abnormal posture or an abnormal contraction of muscles. So the foot might be turned in a funny posture to where it makes it difficult to walk. The hand may be the same way, where it's held in a funny posture, the arm turned in a certain way such that it's difficult to use. So with CBD, we see much more this asymmetry, and more dramatically so than we do with PSP, and that would be the biggest difference. So someone asked about hereditary links, which we talked briefly about, but they said they were a little late to the program. So there don't seem to be very many direct genetic cases of PSP. So if somebody has PSP, their children likely are not at increased risk significantly. So we really don't see much of that. We do think that there's probably a combination of genetics and environmental factors that put someone at risk for PSP. But again, we don't see a lot of inheritance risk except in very rare cases. And then someone asked to describe the difference between PSP, MSA, and Lewy body dementia. So that's a little complicated. MSA is also known as multiple system atrophy, and this is again one of the Parkinson's plus type syndromes. And with multiple system atrophy, we see more problems with what we call autonomic function, and this relates to bowel and bladder function, sexual function, and blood pressure regulation. So generally in people with MSA, we'll see problems with low blood pressure, especially when they stand. We call it orthostatic hypotension. And we can see this in PSP and Parkinson's, but usually not to the degree. So that's really the big one that's different with MSA. In Lewy body dementia, Lewy bodies are the pathological hallmark of Parkinson's disease, and when we see them deep in the brain structures, we call that Parkinson's disease. When we see them more diffusely throughout the brain, it often results in Lewy body dementia. So basically, these people look like they have Parkinson's disease, but they have more prominent cognitive problems. So that's really the big difference there, is they have much more prominent memory problems as well as the Parkinson's symptoms. And in both, or in all three, in PSP, MSA, and Lewy body dementia, we can see what we call Parkinsonism. So this is the slowness, the stiffness that we can see within all these different disorders, and that's where it gets a little confusing sometimes. And then there's a question about, are there other types of eye movement problems you may describe that come from a variant of PSP? So, like I said, the big one is the supranuclear gaze palsy, which I tried to describe. And we can see other eye movement problems as well. So just like the eyes don't move properly up and down, the eyes may not move laterally as well either, and that's where the reading can sometimes come in, and that it has trouble tracking along. So those are the main problems. We also do see the dry eye. I hope that kind of describes it there. Okay, I'm just looking through some more of the questions here. Someone asked about, is giving medications on a very strict schedule important? Can there be a little leeway, a little earlier, a little later? So generally for PSP with medications, it's not as important to have such a strict schedule. We often think about this in the Parkinson's patients. As I said, it comes up especially with the levodopa that I was talking about. And in Parkinson's disease, we'll see people who take a dose of levodopa and get about 3 hours worth of relief, and then the medication wears off, and it's kind of this dramatic, almost like an on-off switch. The medication kicks in, their symptoms get better, the 3 hours are up, and the medication wears off. So when someone is like that, which again we don't see very often in PSP, they need to take their medications on a very strict schedule. People with PSP, if it's a medication like amantadine, that one, the schedule isn't too important at all. If somebody is on levodopa, you might want to do it about 3 times a day, but the likelihood that they would need to take it really strict times is pretty limited. And it's often important to try to work in a medication schedule so that it fits with the lifestyle. So I often try, if a medication's 3 times a day, to do breakfast, lunch, and dinner, if it can be taken with food, so that there's more ability to stick with the dosing of it. Because taking a medication multiple times a day is pretty difficult, and sometimes if you try to get on too tight of a schedule, it causes a lot of other issues and problems. Sorry, I'm just looking through some more of the questions here.
It looks like there's a couple of multiple questions about whether or not swimming would be a good way to exercise. What are your thoughts on that?
So swimming, I think, for most people could be great. I think the importance with swimming is that, again, that it's safe. So it's key that you make sure someone's safe with swimming. So if someone's not comfortable with swimming, I'd be rather concerned. It often would be good with something like that to maybe start with a therapist and see how somebody does, and if they're doing well, then to continue it. But with the water, you just want to be careful and make sure someone's safe for sure. But the great thing about swimming is it's very low impact. It tends to be easy on the joints. Often even just walking in a pool can be quite nice. So the issue would just to make sure that it was safe. I'm having trouble getting through the whole question sometimes. Oh, is that okay? I'm back. Never mind. Sorry. Um, yeah, I'm having trouble at times seeing the whole question coming up.
All you have to do is just click on the question and it'll expand it so you can see the whole thing.
Yeah, it's not working.
Oh, okay.
Um,
I did see a few questions about Davunitide, and I think Dr. Peterson had said that she wasn't really familiar with it. That's a drug that is currently in clinical trials mode, or clinical trials testing, manufactured by a company called Elan Therapeutics out of Canada. That drug will not complete clinical trials testing until sometime in 2013. But it's basically a protein that is administered through a nasal spray. So right now they're trying to figure out whether or not it's effective against other things like a placebo in PSP patients. So information for Davunitide will come between now and 2013. So hopefully they're hoping that that will be very effective.
So, someone also asked about the life expectancy of someone with PSP. So this can vary, and the kind of classic teaching has been 8 to 10 years after diagnosis, but this is often attributed to that Richardson syndrome, so the very classic PSP, and with the other forms of it, we can often see much longer periods that people will stay alive for. And again, if someone's symptoms are progressing quite slowly, they often continue in that way, and so they can have much longer courses. But if someone has a fairly rapid progression, it's not uncommon to see a life expectancy of the range of 8 to 10 years. Someone asked if can some drugs cause PSP. Not that we know of at this point. No, there's not any drugs known of that cause PSP. I think that looks like we've probably gotten through most of them. Oh, someone also asked about home modifications that provide for safety and comfort. So this would really be pretty dependent on the individual, possibly. There may be things like grab bars in the shower, using a shower chair may be quite helpful for somebody. Chairs that can lift people up, so lift chairs if people really have trouble getting up and out of a chair. If people have a lot of trouble with freezing and walking problems that way, sometimes trying to clear the house as much as possible can be helpful, so not having a lot of clutter around, but kind of more open areas. If rugs are causing problems with catching feet on them, which sometimes happens, that can be helpful to try to take away area rugs and try to get more smooth surfaces. The best way generally to work on that is to try to get a home health evaluation, so someone can come actually into the home and see how the person is functioning in the home, and then try to make those suggestions, because it's really going to vary from individual to individual, and then also what the setup of the home is as well. And then a couple of people asked about the vitamin D issues, and if there might be a role for vitamin D in PSP. So the research that I'm doing is looking at vitamin D in Parkinson's disease. And the reason that I am looking at that is that in people without Parkinson's disease who fall, and elderly people who fall, vitamin D seems to decrease falls and may help with balance. So we're looking to see if that's true in Parkinson's disease as well. There's no data that I know of in progressive supranuclear palsy at all in terms of vitamin D. It does seem to be fairly safe, and vitamin D does help quite a bit with bone health and prevents fractures. So I think it's very reasonable for someone to look into what their vitamin D level is and work with their primary care doctor and make sure that it's at a level that's safe for their bones for sure. Taking higher dosages than that or beyond that, there's really not data at this point to do that. But I think it's definitely makes sense to get on a good level for bone health, because there's clear data that that's the case. And when someone's falling a lot, they're at much higher risk for fractures. So it would be good to work with your primary care doctor and getting a vitamin D level checked and making sure that it's staying in a safe range to keep the bones healthy.
I guess
So I think that's probably it.
yeah, I guess maybe I'd like to just close with one of the last questions posed, and that was whether or not head trauma could potentially be a cause of CBD or PSP. Any thoughts on that?
There's not any data that I know for those having any relationship. We do see some Parkinson's, we call it Parkinson's pugilistica, and it's when we see a Parkinson's type syndrome in people with head trauma, but I haven't heard of a relationship with cortical basal degeneration or PSP and head trauma.
Okay. Well, Dr. Peterson, thank you so much for doing this webinar for us. I'd like to thank everyone who attended today. I will remind everyone that we are recording this webinar. We will have a copy available for people to go back and look through. And we will also make the slides available for those who want to further explore the information that's been provided. So thank you everyone for attending, and we definitely encourage everyone to check out the CurePSP website, which is curepsp.org. Thanks so much. Have a great day.
Thanks.